Good day everyone, I am Andrea Wendel Suyom and I'm going to discuss the peripheral nerve injury. First, let's define and know the function of peripheral nerves. Peripheral nerves are part of the nervous system that is outside of the central nervous system. It sends messages from the brain and spinal cord to the rest of the body. These nerves control the functions of sensation, movement, and motor coordination. They are fragile and can be damaged easily. Peripheral nerves are made of fibers called axons that are insulated by surrounding tissues and conducts electrical impulses away from the neuron's cell body. Now, what is peripheral nerve injury? It is an injury to nerves in the upper extremity like radial, ulnar, and median, or in the lower extremity like peroneal, sciatic, femoral, and tibial. PNI or peripheral nerve injury may include damage to major nerves, the nerve root, plexus like brachial or lumbar, and other peripheral sites. It is usually associated with changes in sensation. A nerve injury can affect the brain's ability to communicate with the muscles and organs. Damage to peripheral nerves is called peripheral neuropathy. Peripheral nerve injuries can be mild or serious and can be graded on the Sunderland scale that defines 5 degrees of severity, which we will tackle it later on. Now let's move on to the types of peripheral nerve injury. So there are 7 types. First is brachial plexus injury or burner neck or shoulder nerve injury. As we all know, the brachial plexus are nerve roots attached to the spinal cord on both sides of the neck. They split and move down each arm. This type of peripheral nerve injury affects the nerves beginning in the neck and moving down into the arms and hands. The main symptom of nerve damage here is sharp pain running from the neck into the shoulder and arm, and sometimes with numbness and or weakness. This type of injury can result from a vehicle crash, a fall, or from playing sports. Next is radial nerve injury. The radial nerve moves down the inside of the arm and into the wrist and fingers. It controls the triceps muscle and the ability to extend the wrist and fingers. If you break your arm, you'll have a radial nerve injury. Injuries at work or overuse can also cause damage to this nerve. Symptoms include loss of movement in the wrist, hand, or fingers, pain, and numbness. The next type is peroneal nerve injury or also known as foot drop. It is caused of compression of a nerve in the leg that controls the muscles involved in lifting the foot. This nerve can also be injured during hip or knee replacement surgery, which may cause foot drop. This injury is a distinctive way of walking that results from being unable to bend or flex the foot upward at the ankle. The symptoms include in this type of injury are numbness, tingling, pain, and weakness. Next injury is spinal accessory nerve injury. As we all know, spinal accessory nerve originates in the brain and enables motion in the trapezius and sternomastoid muscles in the neck. A spinal accessory nerve injury can be caused by trauma or damage during surgery, resulting in shoulder pain or winging of the shoulder blades and weakness of the trapezius muscle. The next injury is carpal tunnel syndrome. It is a well-known syndrome that has a widespread peripheral nerve entrapment injury. The median nerve, providing feeding to the thumb and next 3 fingers, has become inflamed and swollen. As it moves into the hand, it must navigate through a narrow space, the carpal tunnel. If the nerve in this area is swollen, it can't move through the tunnel easily, and you'll experience numbness and pain in the thumb and fingers and the side of the hand where the thumb is. If you work, for instance, with your hands during the day, whether it's on keyboard or using a hammer or drill, your risk of carpal tunnel syndrome increases. The next type of peripheral nerve injury is ulnar elbow entrapment or bicycler's neuropathy. The ulnar nerve helps move the hand and lower arm. This nerve branches off of the brachial plexus and moves down the arm through the elbow and through the wrist. Sometimes it becomes entrapped at a site called the cubital tunnel on the outer side of the elbow. The tunnel is a tiny space, so if the nerve is compressed, pain and weakness and tingling in the lower arm and hand may be experienced. While in ulnar wrist entrapment, the ulnar nerve can also be compressed at the wrist as it passes through a small canal. It is similar to a carpal tunnel syndrome, except different nerves are involved. You are more prone in this type of injury if you bike or play golf, tennis, or baseball. By constantly gripping your equipment with your hands, you're stressing the nerve repeatedly. Now let's move on to the classifications of peripheral nerve injury. So we have two classifications. The first is Seddon classification and Sunderland classification. First is Seddon classifications. We have three. First is neuropraxia, axonotmesis, and neurotmesis. In neuropraxia, it is the mildest injury type and does not involve loss of nerve continuity and causes functional loss, which is transient. These symptoms transients if is thought to be due to a local induced conduction block at the injury site, although subtle alterations in myelin sheaths or structures have also been found. In this classification, the neuropraxia, there is a local myelin damage secondary to compression. Compression injury causing temporary disruption of nerve conduction and the whole nerve remains structurally intact. Usually, there is a good prognosis with complete recovery of nerve function in neuropraxia. Next is axonotmesis. So in this classification, the axon is damaged but the perineum and epineuroneum remain intact. Axonotmesis occurs when there is a complete interruption of the nerve, axon, and surrounding the myelin while the surrounding mesenchymal structures including the perineum and epineuroneum are preserved. So the axon and myelin degeneration occur distal to the point of injury, causing complete denervation. So the prospect of recovery in this type of classification is excellent in such injuries because of the remaining uninjured mesenchymal lattice work that provides a path for subsequent sprouting axons to reinfiltrate the target organ. Lastly, the neurotmesis. It has a complete nerve transection and the connective sheath is damaged. Neurotmesis involves disconnection of a nerve. Functional loss is complete and recovery without surgical intervention does not usually occur because of scar formation and the loss of mesenchymal guide properly directs axonal regrowth. So, in this type of classification, the chances of recovery are very poor without surgical repair. While the second classifications of peripheral nerve injury is the Sunderland classification, where it defines 5 different degrees of peripheral nerve injury. First degree injury is equivalent to Seddon's neuropraxia because it involves a temporary conduction block with demyelination of the nerve at the site of injury. So there is a conduction impairment, but the anatomy is intact. The injury does not require surgical intervention and usually will recover within a matter of hours to a few weeks. While the second degree injury is equivalent to axonotmesis, there is a loss of continuity of axons, the electrical wires within the nerve, and then it results from a more severe trauma or compression. This causes Wallerian degeneration distal to the level of injury and proximal axonal degeneration to at least the next node of Ranvier. This type of injury does not require surgical intervention, while the third degree nerve injury occurs when there is a disruption of the axon and there is also a partial injury to the endoneurium. This categorization places a third degree between Seddon's axonotmesis and neurotmesis. In this case, recovery is difficult to predict. The fourth degree nerve injury is there is a damage to the axons and the surrounding tissues sufficient to create scarring that prevents nerve regeneration. So all portions of the nerve are disrupted except the epineuroneum. In this degree of nerve injury, surgical intervention with nerve grafting is necessary to repair the injury. The fifth degree and the last degree nerve injury are usually found in the laceration or severe stretch injuries. This type of degree injury involves complete severance of the nerves. So the only way to repair a fifth degree injury is through surgery. Just like the fourth degree injury, it requires surgery to restore the neural continuity. Now let's move on to the causes of peripheral nerve injury. Peripheral nerves can be damaged in several ways. It may occur by congenital, traumatic, chemical, pathologic, thermal, or mechanical means, but focal trauma is the most common of all PNI. Injury is one of the causes that result from an accident. A fall or sports can stretch, compress, crush or cut nerves or laceration, severe bruising, gunshot wounds, drug injection injury, and electrical injury. While in medical conditions such as diabetes, Guillain-Barré syndrome, and carpal tunnel syndrome, and in autoimmune diseases including lupus, rheumatoid arthritis, and Sjögren's syndrome, and other causes include narrowing of the arteries, hormonal imbalances, and tumors. Now, on the prognosis of peripheral nerve injury, it depends on the severity of nerve injury. Recovery of motor and sensory function is variable. When the nerve injury is very proximal, nerve regeneration may not occur quickly enough to permit muscle reinnervation. However, if surgery is performed within 3 to 6 months after the nerve injury was sustained, the patient can be expected to recover the use of most muscles, excluding muscles in the hand or foot in the injuries at the trunk level or higher. Both proximal and distal nerve injuries can lead to a long-term disability. Some cases may improve with time if the underlying cause is treated, whereas in some people the damage may be permanent or may get gradually worse with time. Nerves recover slowly and maximal recovery may take many months or several years. Now I'm going to discuss the pathophysiology. So there are non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors in peripheral nerve injury are family history of neuropathy, adults over 65 years of age, and then males because males have higher incidence than females. Autoimmune diseases such as rheumatoid arthritis and lupus, and diabetes, metabolic syndrome, chronic hypertension, or kidney, liver, or thyroid disorders. While the modifiable risk factors are vitamin deficiency, alcohol misuse, and viral infections such as Lyme disease, shingles, Epstein-Barr virus, hepatitis B and C, and HIV. Also exposure to toxins and repetitive motion. These risk factors could contribute to the cause of peripheral nerve injury. As I mentioned earlier, the common cause of peripheral nerve injury is focal trauma. Injuries can be direct or indirect. Injury to the nerve may result in demyelination, in which the protective coating of nerve cells is damaged, and axonal degeneration, in which there is a loss of communication between neurons or both. Usually, squamous cells contain multiple axons. Myelinated axons enhance conduction between nodes, accelerating transmission compared to non-myelinated axons. But here in peripheral nerve injury, when a nerve or group of nerves become damaged, compression neuropathy occurs. Compression neuropathy depends on the amount and extent of compression force. Edema, connective tissue thickening, and segmental demyelination of large fibers occur in compression neuropathy. Clinically, both demyelination and axonal degeneration result in disruption of sensory function, motor function, or both in the injured nerve. So when there is disruption of sensory function, it results in loss of sensation to the affected nerve's sensory distribution, neuromatose or cosalgia pain, or both. while the disruption or injury to motor function results in loss of muscle function, and the disruption of autonomic function results in loss of involuntary function. Symptoms varies according to the nerve fibers affected, but here we will categorize them per system. First is if there is an injury to a motor nerve, the symptoms that will be manifested in CNS are loss of sensation, heat intolerance, flaccid paralysis, extreme sensitivity to touch, lack of coordination, hypotension, and dizziness or lightheadedness. Whereas injury to sensory nerve, the symptoms that will be manifested in musculoskeletal are muscle weakness, painful muscle cramps, paresthesias, uncontrollable muscle twitching, numbness or tingling in hands or feet. While if autonomic nerves are affected, there is loss of involuntary function as I mentioned earlier that affect the blood pressure, temperature control, digestion, and bladder and sexual function. The symptoms that will be manifested in GIT are indigestion, constipation, gastroparesis, nausea, and vomiting. While in urinary system are urinary incontinence or retention, bladder discomfort, and in reproductive system is sexual dysfunction like impotence or erectile dysfunction. While in integumentary system, the skin will be warm and dry after injury, cold and cyanotic with loss of hair, excessive sweating or not being able to sweat, or also called hyperhidrosis or anhidrosis, brittle fingernails, and ulceration. The CNS and musculoskeletal system symptoms could lead to complications such as burns, infections, falls, disuse syndrome, sensory deficit, contractures, and compartment syndrome, while symptoms of integumentary could lead to skin injuries. Now we'll be moving on to the risk factors. Earlier, I mentioned the non-modifiable and modifiable risk factors. So, as I mentioned earlier, the risk factors are alcohol misuse, diabetes, infections such as Lyme disease, shingles, Epstein-Barr virus, hepatitis B and C, and HIV, autoimmune diseases, kidney, liver, or thyroid disorders, repetitive motion, such as those performed for certain jobs, and family history of neuropathy, and exposure to poisons or toxins. So, toxic substances include industrial chemicals and heavy metals such as lead and mercury. And in vitamin deficiencies, B vitamins including B1, B6, and B12, vitamin E, and then niacin are crucial to nerve health. Now, on clinical manifestations, the clinical appearance following nerve injury varies according to the nerve affected, as I mentioned earlier. The sensory, motor, or combined. Injury to motor nerves results in loss of muscle function, whereas injury to sensory nerve results in loss of sensation to the affected nerve's sensory distribution. Symptoms often depend on which nerves are affected, like in motor nerves, which we all know that it regulates all the muscle under the conscious control, such as walking, talking, and holding objects. So, if there is damage to these nerves, it is associated with muscle weakness, flaccid paralysis, atonic or hypotonic muscles, progressive muscle atrophy, absent tendon reflexes, painful cramps, and uncontrollable muscle twitching. While in sensory nerves, we all know that these nerves relay information about touch, temperature, and pain. An injury to these nerves could lead to symptoms such as numbness, tingling in the hands or feet, paresthesias, or pins and needle sensation, and you may have also a trouble sensing pain or changes in temperature or loss of sensation in the part of the body that is affected by the damaged nerve. Walking, keeping the balance with the eyes closed, or fastening buttons are also affected. While in autonomic nerve, we all know that this group of nerves regulates activities that are not controlled consciously, such as breathing, heart and thyroid function, and digesting food, or which we call the involuntary function. If there's an injury in these nerves, symptoms that may be manifested includes excessive sweating, changes in blood pressure causing dizziness or lightheadedness, the inability to tolerate heat, and gastrointestinal symptoms such as constipation and bladder dysfunction. Moreover, you may experience a range of symptoms because many peripheral nerve injuries affect more than one type of nerve fibers. So, the following are the specific area that are affected. First is radial nerve injury. So in this injury, symptoms felt are weakness in extension, possible wrist drop, inability to grasp object or make a fist, and there's an impaired sensation over posterior forearm and dorsum of the hand. While in brachial plexus, in this injury, symptoms that will be manifested are difficulty in abduction of shoulder, weakness with supination and flexion of the forearm, or extension of the forearm, or there is paralysis and atrophy of the small muscle of the hand. While in median and ulnar nerve injuries, there is sensory and motor loss of function in the hand and opposition of the thumb, and also paralysis of finer flexor muscles. While in femoral, if there's an injury in this area, weakness of knee and hip extension, atrophy of quadriceps, absence of knee jerk, loss of sensation of anterior aspect of the thigh may be manifested. And the common peroneal, or also called foot drop, there is sensory loss of dorsum, there is sensory loss on dorsum of foot and difficulty with eversion. Lastly, the sciatic, if there is injury in this area, pain across gluteus and thigh, loss of knee flexion, weakness or paralysis of muscles below the knee may be manifested. Now we are done with the clinical manifestations. Let's move on to diagnostics. In order to fully determine the extent of damage to the nerve, the doctor may order an electrical conduction test to determine the passage of electrical currents through the nerves. So two of these tests are electromyography and nerve conduction velocity. So these tests are sometimes done during actual surgery while the patient is sedated. Also, the doctor may order the following imaging techniques: CT scan, MRI, and MRI neurograph. While the other diagnostic tests are the following: blood tests that detect vitamin deficiency, diabetes, abnormal immune function, and other indications of condition that can cause peripheral nerve injury. Other nerve function tests that include autonomic reflex screen that records how the autonomic nerve fibers work, at a sweat test that measures the body's ability to sweat, and sensory tests that record how you feel touch, vibration, cooling, and heat. And then nerve biopsy that involves removing of a small portion of a nerve and usually a sensory nerve to look for abnormalities. And skin biopsy to remove a small portion of skin to look for a reduction in nerve endings. And lastly is the nerve conduction studies. It is useful in identifying the secondary compression sites that may be present, and if there is nerve that is compressed at an entrapment site, such as carpal tunnel and cubital tunnel, axonal regeneration may be impeded. The nursing diagnosis in peripheral nerve injury are the following: impaired physical mobility, risk for peripheral neurovascular dysfunction, chronic pain related to injury, risk for infection secondary to tissue disruption or surgery, and risk for falls. Now we are moving on to the medical management of peripheral nerve injury. Depending on the location and degree of the nerve damage, the doctor may prescribe different courses of therapy. For mild nerve injuries, the following non-surgical treatments may be part of the plan, such as acupuncture, massage therapy, medications such as aspirin or ibuprofen to relieve the pain, and anti-inflammatory medications to reduce the inflammation. Medications used to treat depression, seizures, or insomnia may be used to relieve nerve pain. In some cases, the person with peripheral nerve injury may be administered or prescribed corticosteroid injection for pain relief. Also, orthotics, physical therapy, and rehabilitation to prevent stiffness and restore function and weight loss. While in more severe injuries, it may require peripheral nerve surgery, which is performed by a neurosurgeon. Procedures for peripheral nerve surgery are the following: brachial plexus surgery, carpal tunnel surgery, DRES or DRES procedure, free muscle transfer, nerve repair or nerve graft, nerve entrapment surgery, nerve sheath tumor surgery, nerve transfer surgery, primary nerve repair or neurography, nerve transplant surgery, open decompression surgery, sensory nerve surgery for neuralgia paresthetica, sensory nerve surgery, and then thoracic outlet syndrome surgery. Still on the medical management, restoring function is one of the treatments to restore function of the affected muscles. First is brace or splint. So these devices keep the affected limb, fingers, hand, or foot in the proper position to improve muscle function. Next is electrical stimulator. So these stimulators can activate muscles served by an injured nerve while the nerve regrows. And also physical therapy that involves specific movements or exercises to keep the affected muscles and joints active. Physical therapy can prevent stiffness and help restore function and feeling. Exercise can help improve the muscle strength, maintain the range of motion, and reduce muscle cramps. Also, applying ice elevation of the limb is part of the restoring function. Now let's move on to the last part, which is the nursing management. In peripheral nerve injury, the nurse must protect the neurovascular function of the patient, promote comfort, and prevent infection. In protecting the neurovascular function, the nurse must administer corticosteroids and diuretics as ordered to decrease swelling and development of compartment syndrome. And then keep the extremity elevated to promote venous drainage, and the nurse must perform neurovascular check to evaluate status of injury. And here, the nurse must incorporate tinal sign into assessment, report any changes in condition. And then, post-operatively, the nurse must assist rehabilitation team in re-educating nerves and muscles to achieve function. And then, the nurse must also observe for paresthesias, pain, or altered skin integrity in areas of splinting and casting. While in promoting comfort, the nurse must administer and teach self-administration of analgesics as ordered. And the nurse must evaluate extremity and instruct the patient or client to avoid exposing the denervated areas to temperature extremes, and apply such as devices as splints and slings as ordered. And the nurse must maintain mobility with range of motion exercises and perform gently following administration of analgesics. While in preventing infection, the nurse must assess wound and dressing frequently for erythema, warmth, swelling, odor, and drainage. And the nurse must monitor temperature with vital signs for hyperthermia and tachycardia indicating infection. And also, the nurse must encourage the patient or client to do deep breathing exercises and ambulation to prevent pulmonary complications. The nurse must also encourage the client to eat a diet rich in fruits, vegetables, whole grains, and lean protein to keep nerves healthy. But because the protection against vitamin B12 deficiency is by eating meats, fish, eggs, low-fat dairy foods, and fortified cereals. And then the nurse must instruct the client or patient to avoid factors that may cause nerve damage, including repetitive motions, cramped positions that put pressure on nerves, exposure to toxic chemicals, smoking, and overindulging in alcohol. That would be all for peripheral nerve injury. Thank you for listening.